Hello, everybody. I'm happy to be here today, and thank you, Colin, for just giving me a few minutes to update everybody on SB 16 and SB 93 with where we're at right now. And just as a reminder, I'm not an attorney. I'm a clinical child and adolescent psychologist specializing in transgender health. I work with young adults as well, around college age. I'm on the board of the LGBTQ+ Guild, and I'm a full member of WPATH, and I'm just finishing up my advanced certification accreditation through WPATH as well. So no, we don't have too much time, and so I'm just going to jump right in there. We'll start off with SB 93, so I think we'll have more questions around SB 16. And this was the birth certificate modifications. We did have a win here. It was proposed to be 18 and under. You couldn't change your name or gender marker, but we were able to get that down to 16. And at 15 and a half, you can start the process. So you can go through it all, have court, have it all ready and done, but it would not go into effect until your 16th birthday. A piece of the law, though, that I don't agree with is that it now requires a guardian ad litem. I have had a few clients in the past who chose to use attorneys. You don't need to, you can absolutely do it without an attorney. They chose to because of the age of the kiddos being very young. And just a handful of times attorneys did request a guardian ad litem. That's the only reason that I could really see a need for that. This is just going to be another barrier, and it's another cost to parents, kind of like socially transitioning. I think we can be flexible on how we operationalize that, but that is part of what is written in the law, that the kids have to have socially transitioned for at least 6 months. This hasn't changed. Parent and guardian must give permission for the name and sex change. Another piece of this that is unfortunate that has changed is the birth certificate with the amendment history. So there was a coordination clause with SB 93, and I think it was HB 209. I can't quite remember. It's been a minute since I presented on this. And that was the clause around sports and their requirements for birth certificates. So if they had both passed, which they did, now to play sports, a birth certificate and your amendment history are required. And previous to this bill, there wasn't an amendment history. You got a new birth certificate that was identical to your old birth certificate, and it just had your correct name on it. Now with this amendment history, we're not quite sure how that's gonna roll out. I don't know that it's been decided yet. If either there's going to be a second document that is your amendment history that will be required to go along with the birth certificate anytime you're giving a birth certificate for any reason, or if it's going to be printed on the birth certificate and say amended or amendment history, and then have some lines on that. I'm not sure what will happen with that. And that's kind of the big bummer, and another just backdoor way of trying to get at the law against sports that's currently on hold. They did have a couple of exceptions. If you have documentation, medical documentation to show that you are intersex, you can change your name at any point. And for any parents who decide on name changes within the first year of birth, you can get that changed as well. And in Utah, it's $360 if you file on your own, which there's lots of resources online of how to do that in Utah. You can print out all the documentation that you need. But again, now we're looking at under 16. We are not able to do that unless we fall under these couple of exceptions. So let's talk about SB 16. As you all know, this is the Utah's anti-trans law against minors, basically under the age of 18, not being able to get hormones, blockers, or surgeries, but we'll talk in more depth about that. You are exempt if a youth under the age of 18 had a diagnosis of gender dysphoria prior to January 28th, which is when Governor Cox signed it into law, you are exempt. There are still a few more hoops you would need to jump through, and we'll talk about that in a minute. To get any treatment, you must be in treatment for at least 6 months with the medical provider to be able to go on and receive blockers or hormones. That's just one of the requirements, though. There's also this systematic medical evidence review, and I'm not sure about this. I'm not sure who's doing this right now, and maybe somebody else can speak to that. I'm more on the side of working with DOPL. And another piece that you all are probably aware of is up until the patient's 25th birthday, they are able to withdraw their consent. So they would have given consent, parents would have given consent, kids would have given assent, and up until they're 25, they can withdraw that and sue. And anybody can sue anybody for any reason, but this is now part of the law. So the exceptions, and this came up in a earlier conference around precocious puberty, because we've been using this for decades, blockers for precocious puberty. They're safe. There's not a lot to say that they aren't. And so again, it's just, what can they do against minors to prevent minors from getting the health care that's actually recommended by all major medical and mental health associations? But let's get into a little bit more specifics, because I think this is where the questions come from the most. So, like I said, you're grandfathered in if you had that diagnosis of gender dysphoria prior to January 28th. If you are not on the blockers or hormones yet, let's say you're 10 years old and you're grandfathered in, you're 5 years old and you're grandfathered in. When you get to that point that you want to be on blockers, you will be required to have a mental health evaluation to initiate that treatment. Here's the tricky part. There's only going to be providers to do that mental health evaluation who obtain a transgender treatment certification. And this is the language the state of Utah has used. So previously, and in meetings I was in with DOPL, what they had said was any therapist that sees any child has to have this transgender treatment certification. And they continue to say that that was kind of the spirit of what they were going for when they were writing the law. However, now the most recent current interpretation of the law, according to DOPL, is that it is only for practitioners who want to provide this mental health evaluation. So that's a big, big difference. Hopefully this is what will stick. Hopefully this is what's gonna actually be the fact moving forward, because this obviously makes a really big difference. But there's still some caveats to the transgender treatment certification. So let's talk a little bit about that. So DOPL is going to create this certification, the criteria for this, by July 1, which is in maybe 5 weeks. So I've been working with DOPL, myself, Dr. Michalopoulos, a couple other people. We've been working to make 2 tracks to this treatment certification, because this is for medical and mental health providers. So there will be the medical track to obtain this certification, and there will be the mental health track to obtain this certification. It will go into effect starting on January 1. Most likely, and I can't say that this is set in stone because we are working on drafts. As of a week ago at this time, 3:32, I was the only person working on that mental health track. And as of a week ago on Monday at 8 p.m., I now have this committee, which is awesome. We have a couple of other psychologists and social worker, who all either specialize in transgender health or working with children and adolescents or both. And we've gone through several drafts already, and we're looking at having required content areas for this that you'll have to show you've met these certain content areas like information, knowledge, and whatever we've decided those are. And then there's also going to be multiple pathways to the certification. And this is important to know because in order to get this certification, initially, you will have to have completed 40 hours of education specific to trans healthcare of minors. And we're trying to expand that because if it all has to be of minors, like I'm not even sure where we would get all of those trainings. Even today, you can see lots of times we're talking about minors, but that presentation is not specific to minors. So we're still working out the details on that, but we're trying to have that be more flexible. And then you're going to have to renew every 2 years at your licensing cycle, whenever you renew for that, which I think is September of even years, maybe. But you will have to complete an additional 20 hours of CEU specific to minors. So it's a lot. And we know that, and that's why we're trying to come up with a lot of different options of things that will meet the criteria. And I don't want to go into too much detail about that because we only have drafts, and both until the AG signs off on how we're interpreting the law at this point, I don't know that might not change. And again, until it's signed off on what criteria we come up with, that can change. So just know by July 1, we have to have it created. I don't know how long the AG's office will take to get back to us in terms of if they want something out that they don't like, or they want something changed, modified. I'm not sure about that. There's still a lot of questions. There's a lot of things that we don't know. But we're trying our best to work with DOPL and to make the best that we can out of this, given that it is law now in the state of Utah. Well, will be January 1st. The requirements to have that mental health evaluation, whoever that provider is, whoever has that transgender treatment certification, that mental health evaluation can't be provided by somebody who's recommending or providing the hormones or blockers. As I'm reading this says to me that we can't do the mental health evaluation on our own patients, but I don't know if that's correct or not. Maybe somebody here could speak to that. We'll get clarification. I think we meet with DOPL Friday, maybe again. I'm not sure. You have to have at least 3 sessions with that minor before you can give that report that you're giving to the medical provider. You have to document that all mental health diagnoses, whatever they're having, documenting them all, and also documenting any life events that could be contributing to those diagnoses. And you also have to determine if that child does actually meet criteria for gender dysphoria. So there's a lot of gloom and doom in all of this. And I just want to remind people that if we want to instill hope in our youth, we've got to find a way for us to have it too, which can be very difficult, both if you're a member of the community. You know, I'm non-binary, trans, masc, and it's been really hard personally. And we have to find a way to try to work through that so that we can give that hope over to the kids that we work with. And we know representation, you know, when we have representation, when we see ourselves in TV shows and podcasts and books and movies and things like that, that helps us to feel better. In fact, I think it was 89% of the LGBTQ youth who saw themselves, with that representation reported feeling good or feeling better about being LGBTQ youth. So anytime we can remind kids about that, we want to do that. Same goes for resiliency, as we're building resiliency, that's enabling us to have those tools to fight that minority stress that we experience. And we want, again, to do that. And protective factors. So much of the same. And I know I don't want to take too much time, but I just wanted to take one moment to remind us that, the conversation's not over. And that's what I keep telling all of the kids that I work with and all of the parents that I work with. There's going to be opportunities to continue to talk to legislators. I met with a senator last week. I'll be presenting to the Democratic caucus in a couple of weeks. They want to continue to hear from us. They want to know what else that they can do, as we anticipate there's going to be more amendments that will be proposed down the pipeline. So, we just want to let them know that we're not done. We're not done fighting this, and we're going to keep doing everything we can to make sure that protecting trans rights for kids actually is based on fact and data and research and not fear. I will skip this part and just leave you with that.
Thank you so much, Dr. Kuhn. We really appreciate you providing that incredibly valuable information about what's happening right now in Utah. I'm going to pull the camera back a little bit to talk about the ways in which Utah's situation parallels what is happening in a lot of other parts of the country, and also talk a little bit. I appreciated that one of your last slides there was about advocacy and resilience, some of the ways that we as providers or medical experts or just folks who care can show up for the trans young people in our lives. So let me share my screen without much further ado. I love this, the magic of virtual conference. I am going to talk a little bit about this, again, this broader landscape, and then bring it into some of the conversations around advocacy. And then we'll be joined by State Senator Jen Plum, who's going to talk from her perspective about what's happening and what's next in Utah before we break for questions. So my name is Kellen Baker. I use he, him pronouns. I'm the executive director of Whitman Walker Institute. We are the research policy and education arm of Whitman Walker, which is a community health system in Washington, D.C. that is affiliated with a federally qualified health center, Whitman Walker Health, which turns 50 this year, celebrating 50 years of service to diverse communities across D.C., but with a particular focus on LGBTQ+ people and people living with HIV. And I'll talk a little bit more towards the end of my presentation about some of the work that we're doing specifically at Whitman Walker Institute in order to try to contribute in any way that we can to efforts to make life bearable and make care accessible for trans young people across the country. So just a brief look at the legislative landscape. Unfortunately, what is happening in Utah is not a one-off event. There are, of course, a number of bills in Utah, and there are a lot of bills that have been filed across the country that are seeking to restrict access for transgender people to many, many areas of their lives, not just healthcare, but also access to participating in sports teams, access to appropriate facilities, very rigid definitions of sex in the law in ways that seek to make it seem as if transgender people cannot exist. And of course, particularly in states like Florida, efforts to ban even talking about the existence of queer and trans people in schools. This is the specific status of the healthcare ban. This is actually changing even as we speak. This was last updated in the middle of last week. And since then, Texas has gone ahead to pass its ban on gender-affirming care, best practice medical care for transgender young people. You can also see here, though, an increasing legal trend, which is these quote-unquote shield laws. These have been passed by a number of Democratic-controlled states seeking to restrict or forbid the use of state funds to help another state enforce a ban on gender-affirming healthcare. And so we can see really this map reflecting, unfortunately, some of the political divides that have become an increasing feature of the US landscape. And so that everyone knows where to find this, you can see the source at the bottom, but the Movement Advancement Project, lgbtmap.org, is the source for this map and many other great resources about the status of laws and policies affecting LGBTQ+ people across the country. Also happening in the context of some pro-LGBTQ laws, there are still conversion therapy bans. Of course, the Utah legislature recently voted to enact its conversion therapy ban on a permanent basis, expansions of coverage for gender-affirming care, the sanctuary states or the SHIELD laws that I mentioned, and then some instances of states updating their non-discrimination laws to include gender identity. There's also a great deal happening in the federal level. It is, of course, tough in the relationship that we have between the states and the federal government in the United States. There's actually limited reach in some ways for the federal government into the activities of the states, particularly around things such as medical licensure, which is historically the province of the states, as well as a great deal of insurance regulation. But we are seeing, for example, the Transgender Bill of Rights being reintroduced. The Equality Caucus and the Progressive Caucus in Congress are both working hard to raise the visibility of the issues affecting transgender people. There's also at the bottom here, I want to note the Affordable Care Act Section 1557 rulemaking. This was the part of the Affordable Care Act that prohibited discrimination on the basis of race, color, national origin, age, sex, and disability. The Obama administration interpreted those protections on the basis of sex to include gender identity, which the Supreme Court affirmed in an employment context in a 2020 case. Nevertheless, the Trump administration sought to take those protections out of the 1557 regulations, and the Biden administration is trying to put them back in. And I have no doubt that many of you in the audience hopefully participated in the public comment period on this last year, and that will currently being finalized. We hope to see it, although there's no guarantees on timing, in the late fall or early winter of 2023. So looking specifically at these bans, there are a number of major themes, and Dr. Kuhn outlined a number of those. For example, banning the provision of care, restrictions on providers, how providers can interact with their patients. And these are themes that we see coming up in other states as well. Bans on puberty delay medications, gender-affirming hormone therapy, surgeries, really bans on best practice, evidence-based medical care for transgender young people. There are variations. Some states are specifically going after social transition. Some have different age limits, and some, like Utah's, have a grandfather clause, while many others, unfortunately, do not, leaving transgender young people who are already in care with little to no recourse unless they can move out of state. Prohibitions on funding. This has been something that has been happening with regard to, for example, Medicaid in a handful of states, as well as a requirement in some states that federally supported facilities, such as academic medical centers, shut down gender-affirming care clinics as a condition of receiving state funding. And I'm going very quickly through this because I want to make sure that we have time for Senator Plum, as well as conversations amongst all of us. So please do note that you will have these slides for your reference after this presentation. There are a lot of interstate implications in a lot of these laws. This is a page that's taken directly from the anti-abortion playbook, seeking to make it impossible not only within a state's boundaries, but even to travel outside of a state in order to access care. And some pretty concerning, vague language. I think one of the things I took away from Dr. Kuhn's presentation is that there's so much that's unknown. And unfortunately, bad actors in the political space are really, of course, seeking to capitalize on the fear that can be instilled by the unknown, which is one of the reasons why this process with DOPL is so important, to try to figure out, put guidelines, put parameters, put some definitions to the vagaries that are in the law. Criminalizing providers and or parents, again, as I'm sure all of us are aware, some of these laws specifically authorize civil and or criminal action against healthcare providers. They also allow, in many instances, state agencies to charge parents with child abuse or neglect, or even to take parents away from their children or seeking to support them in access to gender-affirming care. And insurance restrictions, making it difficult or impossible to obtain malpractice insurance. And again, you heard a little bit about this from Dr. Kuhn, but essentially making it such a chilling environment that insurance carriers don't want to cover this care, and then by extension, that it becomes even more difficult for transgender young people to access it. Restrictions on providers, for instance, limits on the types of providers that are allowed to provide care. Florida has banned the provision of gender-affirming care by anybody who is not a physician. So leaving out, for example, NPs and PAs. So where is this coming from? This isn't coming out of nowhere. This is really being fed by a really unfortunate nexus of an eager media and an astroturfed movement to make it seem as if there is a political controversy around the provision of this care. You may recognize this. This is the headline picture from an article in the New York Times last year, hyperventilating about they paused puberty, but is there a cost? Concerns are growing. Next up at Channel 9 News at 11. So whose concerns are growing? If we look at the network of organizations behind these bans, there's a lot of organizations in that network, and something striking that you'll notice, a lot of them are quite new. What's really happening here is as conversion therapy has been banned increasingly across the country, conversion therapists, people who are seeking to make it impossible for transgender people, and particularly transgender young people, to be who they are, they're increasingly turning to these really broad-based medical care bans to make it difficult or impossible for trans young people or trans people generally to access the care that they need. And this is a really excellent investigation by a website, a group of researchers who write at Health Liberation Now, looking again at this kind of very tightly networked universe of people who are purporting to advance this idea that there is a controversy in the medical community about trans identities and about gender-affirming care. There's a lot of purported expertise by people who don't actually have the expertise to back up what they're claiming. For example, a medical expert in a court case in North Carolina having his testimony excluded by a federal judge who ruled that he is not qualified to render opinions about the diagnosis of gender dysphoria, its possible causes, the efficacy of the DSM, et cetera, et cetera, et cetera. But this is the type of person who's being put forward by that network of organizations that you saw on the previous slide to claim that medical experts do not agree that gender-affirming care is efficacious, safe, and helpful for transgender people at any age, including individualized age-appropriate care for transgender young people. There's also one over here, Dr. Paul Hruz from Missouri, who is testifying in favor of a ban on gender-affirming care. And the judge essentially threw him out from the very beginning, saying, if you've never treated a transgender patient, which he admitted he had not, how is he going to testify about treatments that he's never given? Whose concerns aren't growing? Literally anybody else's who's not part of this really fringe movement that is working to discredit the experts who work with transgender young people and seeking to themselves. There have been 20 major medical associations. In fact, literally every single major medical association supports and endorses the importance of gender-affirming care for the well-being of transgender people. So what can we do to fight back against this narrative that would have us believe that transgender identity is not real, that transgender people shouldn't be safe and affirmed in being who they are? One of the things that we can do is continue to cite the evidence. I have included a slide at the end of my presentation that has a number of references that I would recommend to those who are looking for resources on exactly what does the science say about gender affirmation for young people or for transgender people at any age. But essentially it boils down to social support, that is affirming a chosen name or pronouns or choice of clothing, decreases depression and anxiety, decreases suicidal ideation, makes life easier and better and more fun for trans young people. Gender-affirming care, including puberty delay medications, hormone therapy, and for adults or for older adolescents in very specific circumstances. Again, gender-affirming medical treatment is associated with improved mental health, life satisfaction, and quality of life, and reductions in gender dysphoria. By contrast, anti-trans legislation really does hurt people. There's a number of resources that are out there that can give a little bit more context to exactly how damaging it is to have your identity and your access to care treated as a political football. There is a real need for expertise like that in this room. I'm very sad that I'm not able to be there with you in person because I know that there's a great deal of expertise, commitment, and dedication among the experts, the providers in this room today. Misinformation that is weaponized, I should say disinformation, which is weaponized misinformation, when you take something that you know is not true and you intentionally use it, that's running unchecked. There's a lot of knowledge gaps about trans identity and about gender-affirming care, and those knowledge gaps are being exploited. We really need healthcare providers to step up and use their voices, use their authority and expertise in support of trans young people. There are a number of ways to do this, including expert testimony, whether that's in a legislature or in a court case, meeting with legislators one-on-one, op-eds, letters to the editor, speaking with reporters, doing public educational events, and activating your networks, speaking out, for example, in your professional society. None of these are the kinds of things where you are going to really need to worry about lobbying. You should touch base with a government affairs professional, for example, at your institution. But all of these things can and do fall under the educational exemption for lobbying, where you can actually use your expertise, share your expertise as a member of the public for educational purposes. These are just some core messages. I want to move through these very quickly because, again, I'm excited to have Senator Plum join us. But the thing that I will leave everybody with for my portion of this presentation is that the main message is that supporting children, supporting people in being who they are, sets them up for a happy, thriving childhood and adulthood. And that's what we want for all of our kids, whether they're trans or cis. Any parent, any healthcare provider, any educator, any concerned adult, all we want to do is make it possible for kids to grow up safe, happy, and healthy, and with the support and love of their families and the support and assistance of the healthcare providers who can make sure that they have the care that they need. So with that, I will turn it over to Senator Plum and look forward to questions and discussion. Thank you.
Okay, have I entered the right spot? I can see all of you chatters, virtuals, not chatters, and I can also see the folks in the room. So I'm guessing I'm in the right spot. I'm really grateful for the opportunity to be able to be here with you, present a little bit of a snapshot of what it was like to actually be in the space where these pieces of legislation were being presented. I'll use the term discussed, as well as being passed in the state of Utah. It was my very first session as an elected here in Utah. So I represent the district where we actually are right now. So kind of a broad swath right down through Salt Lake City, Low Avenues to 17 South, Immigration Canyon down to Redwood Road. But many of us that are in the Democratic caucus feel like we represent a far bigger group of folks than just our geographic group, because we know that there's only, for example, in the House, there's one Representative Lesser, who's up in the Ogden area, and the rest of the Dems are all Salt Lake County. So we feel very strongly that we are a voice for the folks everywhere else in the state who are not likely represented by the folks that are elected to represent their zones. I got into this arena for a couple of reasons, but I'm a pediatrician and ER doc, and I've worked a lot on opioid overdose deaths. And I've watched good policy get passed to actually change the way people look at folks, to watch culture shift happen. And then as I got the honest to God blessing to get into this space with my own daughter, navigating, the transgender and gender affirming care space, I realized I really didn't want to see what was happen any more than it already was. And also felt like there needed to be a softening and an awakening that was happening for the folks that were making and considering policies. It's actually really reaffirming to me to hear the things that Kellen and Dr. Kuhn were talking about, because I watched this happen. And these folks straight up came in with their fear-based agendas and terrified people right and left. And look what happened. So to see a little better picture of this made me go, oh, okay, I wasn't losing my mind. That's really what is happening here and elsewhere. And so, there I went in, careful what you ask for. Sometimes you actually get it. And I went in as an elected. My very first committee hearing was Health and Human Services, where they were debating Senate Bill 16, very first hearing. And I had been there as an advocate, as a doc, as a mom on the other side, where you were, sitting with the microphone and trying to hope that someone hears you or feels you or relates to you or something. But to actually sit up on that dais or square, I don't even know what they call it. I'm learning the words still as being an elected, but and here, what I felt like was truly a very organized small faction that had been flown in from all over the country, a young person who undoubtedly has some decent struggles and issues that I hope that they get help with. And I also hope that these bullies who are using that young person for their pulpit, I hope that they stop abusing them, because it is very abusive to me to see this poor person one time after another time after another time. I can't imagine the frequent flyers this adolescent has, frequent flyer miles this adolescent has, because they just keep getting dragged in front of folks to tell this really traumatic and traumatizing experience they've gone through. And then you have these experts that are going to tell you the things. And there was a doctor, I wish I could remember his name, but I listened and I was trying so hard not to just light on fire. And I've been in academics for a lot of years, since like 1996, and so they were from the Manhattan Institute, which does sound a little Supermanish, right? Like it's kind of got that vibe to it. But and in my mind, I wanted to pull up my computer and Google them. I wanted to try to figure out what it was. Well, now I know what the Manhattan Institute is. It's a policy institute, a very conservative policy institute. I had no idea at the time. And he was introducing himself as doctor. And so after all this, I kind of said, hey, can I just ask a question of the doctor again? And they came up and I explained to him, can you tell me a little bit more about this Manhattan Institute where you practice? Can you tell me about, the amount of care that you may have provided to youth at all, or to transgender youth? Or can you just give me some, I don't know, framework for me to be basing the way I and my colleagues should be thinking about the things you said? And he said, oh, I have a PhD. And honest to God, I was like, every single one of us up here on the thing, when you said doctor, myself included, thought y'all were a clinician. We thought you were someone providing care. No, this is a PhD in political science from this guy. Never did anyone announce anything about that. Never did anyone say anything about that. And I wish now, knowing the things that I had, I would have had some of these, like the judges said, like, oh, so why are you qualified to speak here? I mean, I'm now wishing I had them and will have them moving forward. But these folks have no question in my mind an agenda, and they have moved it very successfully across this nation. And it's not even just in our policy spaces. I think it's in the spaces the media reaches, right? It's in the places where folks who didn't have any concerns or worries, much exactly like Kellen was saying, which didn't have any concerns or worries and left medical care to be between providers and families and patients, now have concerns because someone has thrown concerns at them and they have stuck. So we tried some different strategies to both bring attention to our fellow legislators about how clearly directed at our trans youth these bills were. So when we talk about surgeries and gender affirming surgeries in less than 18-year-olds, my colleague Senator Escamilla made a motion to add all surgeries on any child less than 18 that would say involve breast tissue, which I thought was genius. Because if we're truly saying that that's developing tissue and we shouldn't be monkeying with it, whatever the right term you want to use is there, And those folks would have been smart enough to see that, you know what, that's actually what we're saying. We should put that in there. I saw some data from a plastic surgery association. There had been like less than 300 mastectomies or chest wall surgeries performed for gender affirming care. And there have been over 250,000 performed for other cosmetic reasons on humans less than 18. And let's be honest, being more or less of this is gender affirming on some level, right? Like just who you are and what you want to be and how you want to look and how you want to be perceived. But this is very clearly directed just at that small population of folks in the gender dysphoria and transgender space. So they didn't take the bite. I kind of wish they would have. They didn't take that bite. They wouldn't allow us. Utah technically, although it has banned, it's actually called a moratorium. You know how it is in Utah. We like to use the nicest. Someone told me, oh, Utah, the nicest bigots you'll ever meet. And it really is kind of true, right? We like to kind of just sugarcoat things that are not really all that pleasant when you look at the face value of them or the true value of them. We tried to see if could we take a 3-year stab at this? Can we put an end on this moratorium? Because without a moratorium end, it's actually still a ban. They weren't interested in that. We did get them to add when I think Dr. Kuhn and Kellen, maybe either one of you or both of you mentioned the data review, the systematic data review. Initially, they had that called a research or a study. And I was like, that'll take 10 to 20 years by the time you get IRB approval. So we did get, I think, the wording changed to a way that there is actually a product that can come out and hopefully redirect the way folks are thinking about this. Department of Health and Human Services is the one who's responsible for that study. I'm still awaiting emails back from them as far as who's been assigned and who's responsible for that and what our timelines look like. And will probably shock no one in here that you have to hold a little bit of feet to the proverbial fire to make things happen when folks are uncomfortable with them happening. So we did get them to not only include the University of Utah, but Intermountain Healthcare. And I am looking forward to meetings with Intermountain Healthcare after some of their recent choices in this space about how they can defend themselves as a healthcare organization. So thank you. So, that was my whirlwind into it. And I had to kind of make the conscious decision, and that as much as I wanted to lose my ever loving mind and be on fire up there, that this ball was rolling, this ball was going. And I felt like it was really important to bring my hope of calm for my colleagues and that I could get their hearts to soften. And I will tell you, I did see there was at one point later in the session when we were trying on a horrible bill. I work in harm reduction, which is like overdose death prevention, syringe exchange, naloxone, all this sort of stuff. It's harm reduction. Being in the Utah State Legislature is harm reduction. Like that, all you do is harm reduction all day, every day. There's potential dangerous stuff and you're trying to make it less dangerous. There's potential crappy stuff, you're trying to make it less crappy. That's truly what that space is. And so, I saw later on in the session that there was a bill, a lousy bill that regards, it's kind of a, I don't know what the right term is for it. We behind closed and not so closed doors called it kind of a white fragility bill. That was what our educators could and couldn't talk about sort of thing. And we were trying to get gender identity included in the protected spaces as it is for every other, Utah state piece. And suffice it to say that in order to get that added, I would have to get over 15 senators to stand for it. And I got 16 of them to stand. And these are not the folks that you would picture. These are the folks that, you would not have thought would ever get their butts off their seats. And they did. So again, I'm really just hoping that those of us that are in the spaces can make there be less hatred, less fear, less cruelty, and have humanity, which is what this state purports that it does, right? The child first and always is the right across the hill at Primary Children's, and it's not what we always do. So I would love to hear questions or thoughts from any of the rest of these box faces that are here. Know that there is a very dedicated group of a super minority up there, but who are not letting this die down, not letting this go away, not going quietly into any nights. So
Thank you so much, Senator Plum. Erica, are you moderating question and answer, or is that something that I can do.
You can do. I was just gonna walk around and give people the mic. Anyone with questions?
I mean, it is the end of a long day. I'm guessing folks are fairly heavy.
There's actually
waiting.
there's quite a few questions in the chat here.
Excellent. Okay.
So I'm happy to read through some of those. And I think Dr. Kuhn and Senator Plum, you will be well positioned to answer them. In full disclosure, I am a PhD, so I have never delivered a baby and am therefore not a real doctor, per the Wall Street Journal. But I did transition, those of you who were on the roundtable earlier today, I transitioned 20 years ago in Russia, and it was easier than this situation is now, which I think just it's very unfortunate, the directions that we're going. And I'm so glad, Dr. Kuhn and Senator Plum, that you are in the roles that you are, working to safeguard access to care for trans young people. So I guess let me, Dr. Kuhn, there's a question here. If an adolescent starts gender-affirming care in another state, are they allowed to continue their care in Utah? So if they're coming from another state, they're now in Utah, they've been on gender-affirming care, hormone therapy for more than 6 months, can they continue?
That's a great question, and I tried to answer that a little bit in there. It's actually a question we've asked as well and haven't gotten a clear answer to, but we're hoping that the answer will be yes. We do have a pediatrician in Colorado that is willing to work with us. Excuse me, and our hope is that if they can initiate treatment there, that they'd be able to then come here and continue their care. Since we're not initiating it here, we're just continuing it. So fingers crossed that will be something we can do.
Good to know. Senator Plum and Colin, I imagine you may have some thoughts on this as well, but can you tell us anything more about what this evaluation report is supposed to look like? Senator Plum, you talked a little bit about some of the changes that you were able to secure, moving it more in the direction of a systematic review rather than a prospective longitudinal study, which, as you noted, would take a decade or more. Can either of you, and maybe starting with Senator Plum, talk a little bit about the changes and what that report is currently envisioned or required to be?
Boy, I honestly wish I had a relatively intelligent sounding answer. I don't. I think that it was put in there as a way to say we are having a moratorium until, this is kind of the reason we're inserting a moratorium until this study, evidence-based review, kind of whatever that is. And it has not had clear definition, or for me, even, kind of what are the goals of this? What are the, benchmarks? I don't feel like there's been clear definition of that at all. I don't know, Dr. Kuhn, it's not really in the DOPL space where you've been spending more time. That's why I'm really hoping DHHS can give us some clarity, because honestly, on some level, there are some really great meta-analyses that are out there of, I can think of one off the top of my head that I shared with several of my colleagues that was like the review of 55, I think, studies that is, I mean, these have been done. It's just a matter of us reviewing them, repackaging them, and presenting them in my mind, but that hasn't been made clear.
I'm glad, just to mention quickly, I was the author of that review. It's through the What We Know project at Cornell University. And what that review sought to do was really bring the primary literature to the forefront. Often there's a kind of screen between interested members of the public or the media or policymakers and the actual evidence. So the purpose was to do a comprehensive search of the literature and present that information for folks to review on their own. That was done in 2017, 2018, and the literature has expanded even much more, particularly with regard to care for young people. So there was a very robust effort. The one last thing that I will say about systematic reviews before turning it over to Dr. Kuhn is the World Professional Association for Transgender Health, which has maintained standards of care continuously since 1979, recently put out the standards of care version 8. That was in last fall of 2022. And that was informed by a Delphi process, which is an iterative process of soliciting expert review among more than 100 experts from around the globe. And its recommendations are based on systematic evidence reviews that were conducted by an independent team at the Johns Hopkins Evidence-Based Practice Center, where I was a member of the team that conducted those systematic reviews. So there is an idea that the WPATH standards are not evidence-based. And let me tell you, as someone who spent years wading through paper after paper after paper after paper, those recommendations are evidence-based, and there is a robust evidence base for the efficacy and effectiveness of gender-affirming care. But Dr. Kuhn, I'll turn it over to you for your thoughts and additions as well.
Yeah, that's exactly what I was going to add about SOC 8, that, you know, the information that they're looking for already exists. And I don't know why we need to rewrite the book when we have the book loud and clear right in front of us with the click of a button. So it's just another, for me anyway, infuriating piece of the law that was added in.
I feel
I call it scientific microaggressions because it keeps us running, you know, chasing our tails in circles, proving the things we already know, because exhaustion is a tool of oppression, right? They are trying to make us so tired and so demoralized, which is why Dr. Kuhn and Dr. Plum, Senator Plum, I appreciate Dr. Plum, the message of resilience and hope and support, because it really is an attempt to keep us so downtrodden that we can't stand up for ourselves, let alone for the young people in our lives.
Yeah.
So if we include you in those dialogues, that it's not really, why can't I think of the word? We're not really copying your paper. If you participate with us in some of those, why can't I think of the word? You know the word? Plagiarizing. Thank you. Yes, plagiarizing.
I give you full consent to use whatever is helpful.
Okay. Well, either that or, like I said, we'll have you sign in on one of the meetings, and then there you are as one of our participants.
Happy to. And I should say, I realized I neglected at the end of my presentation to give a little bit more information about one of the initiatives that we have underway at Whitman Walker Institute in partnership with GLAMA, Health Professionals Advancing LGBT Equality, and Trans Health Northampton, which is a clinic in Massachusetts. We have convened a coalition called PACT, Protecting Access to Care for Transgender Youth. And its purpose is to bring together providers, researchers, and other advocates and experts in this space who want to raise our voices in support and defense of trans young people and the care that they need. We have regular meetings, and you can find out more about that coalition. We are revamping our website, which will be launched soon. But in the meantime, you can find some more information out about that in my slides. And please feel free to contact me by email or through the Whova app if you are interested in participating. I have a couple more questions here, and so some of them can. Oh, great, go for it.
Who could speak to it? So will someone provide a quick summary of the very recent changes at Intermountain Healthcare and how these changes affect the care of clients or patients with select health insurance?
All right, my name is EJ, using your pronouns. Hey, Callan, how you doing? It's good to see you up on the screen. So I work, excuse me, I work at Intermountain. I'm the LGBTQ program manager there. I'm actually on a leave that started May 1st. So Select Health, as a payer, still continues to cover all the care. People need to go to their medical policy or call the advocates from Select Health and have a conversation. So that's first. Care is still covered. There was a recent decision within Intermountain to not allow any medical group surgeon, so any employed surgeon or facility, to allow vaginoplasty, phalloplasty, or metoidioplasty for the diagnosis of gender dysphoria. So we came here to do that. I moved here to do that. And so there are some alternative plans for our surgeon to potentially open a private practice to be able to continue to provide the services. We're still allowed to provide top surgery, breast augmentation, orchiectomy, hysterectomy, oophorectomy, and hormones, and hair removal, and all the other services, just not those three specific bottom surgery procedures.
I think we probably have time for one more question. Regarding the right to revoke consent up to age 25, is that only for interventions performed? Oh, somebody. Sorry, somebody moved the app. Is that only for interventions performed prior to age 18, or does that include any interventions performed between ages 18 and 24?
Where's the lawyer?
Yeah, I was gonna say, I think you need a legal scholar.
Yeah.
Yeah, I was gonna say that's another one of the questions. I mean, there's just so many things that are unclear because this law is really poorly written. And I have worked with several lawyers, and we have gone back and forth so many times on so many aspects of this law, which is why I say where we've landed right now, this still isn't set in stone. I think it's the best, that we've got, but that's just another question I can add on to my list of questions to have them to the powers that be. Tell us what you think here. What about this situation? What about that situation? We don't know.
Then another one is, are gender diverse people in Utah still required to stand in front of a judge and state that they have no history of being a sex offender? I remember this being a major barrier for changing birth certificate and social security cards.
They're still required to get a report that affirms that they do not have any, at least in my family's experience, that you had to get the report from the, I don't know if it's the corrections officer or whatever, that you're not on the sex offender list.
Yeah,
or
the
you're not.
sex offender registry or something like that.
Yeah, so in terms of standing in front of a judge, it wasn't that so much, but it still was a requirement to get that report.
Yeah, that's
Someone who writes the letters for the gender marker change. I know that with some of this legislation, the requirements for what's in those letters has changed pretty dramatically. So we used to just be able to say that, we are treating them and they meet the clinical criteria, and we affirm that this is true and correct. And now it's a much larger sort of biopsychosocial picture.
I'll tell you something that you just made me think of by bringing up the judge bit. Something I think that people should know about, and I didn't know about until I was elected and placed on something called the Judicial Conduct Commission, is that any reports that you file about being mistreated, misgendered, not treated appropriately, or what I would say is responsibly by a judge, you should absolutely report. It will absolutely be looked at. And I will be there for at least 4 years. So these are things I didn't know existed. And when I hear about people being treated poorly by a judge, it just makes you sick to your stomach. But there actually are remedies, and that's not okay. So if you hear of it happening, have it happen to you or someone you care about, get the report in, because we will make sure it's investigated and dealt with.
And with that, I think we'll thank our panelists for their time. And thank you again all so much for your expertise. And really, really complete.
Thank you all.
Oops. Yeah, thank you for allowing me to hop on at the last minute.
Very glad you were here. This is really wonderful information and really very much appreciated. Thank you, everybody.